If you have noticed that your ankles look larger at the end of the day than they did in the morning, or that pressing a finger into the skin above your ankle leaves a temporary indentation that takes several seconds to spring back, or that your shoes feel noticeably tighter in the afternoon than when you put them on, you are experiencing what medicine calls peripheral edema, which is the accumulation of fluid in the tissues of the lower legs and feet. This is one of the most common physical complaints across all age groups, and it becomes increasingly common with age. It has multiple causes, some of which are benign and addressable through lifestyle and nutritional intervention, and some of which indicate underlying medical conditions that require evaluation and treatment by a healthcare provider. I am going to walk you through both categories clearly, because knowing the difference between swelling you can address yourself and swelling that needs medical attention is genuinely important information that could affect your health significantly. Before I discuss any nutritional intervention, I need to be direct about the medical causes of leg and ankle swelling that should prompt you to seek evaluation rather than attempting home management. If your swelling is sudden and significant, appearing within hours rather than developing gradually over days or weeks, see a doctor promptly. If the swelling is in only one leg rather than both, particularly if that leg is also red, warm to the touch, or painful, this is a presentation that can indicate deep vein thrombosis, a blood clot in the deep veins of the leg, which is a medical emergency requiring immediate evaluation. If you have swelling accompanied by shortness of breath, chest pain, or significant fatigue, these symptoms together can indicate heart failure or pulmonary embolism, both of which require immediate medical care. If you have swelling accompanied by decreased urine output, foamy urine, or significant fatigue, kidney disease may be involved. If your skin over the swollen area is tight, shiny, or you have developed open sores or wounds in the swollen tissue, you need medical evaluation. I want to be clear that if you have any doubt about the cause of your swelling, the appropriate first step is always to have it evaluated by a healthcare provider, not to begin a nutritional intervention and hope the swelling resolves. This video covers the nutritional side of a condition that often has a nutritional component, and it is most relevant to people who have already had the serious causes evaluated and ruled out, or who have swelling that is clearly associated with the common benign causes I am about to describe. With that said, let me explain what is actually happening in the tissue when fluid accumulates there, because the mechanism is the foundation for understanding why specific nutritional interventions work. Your circulatory system continuously moves fluid, the liquid component of blood and lymph, through a network of blood vessels and lymphatic vessels throughout your body. In the capillaries, the smallest blood vessels, fluid is exchanged between the bloodstream and the surrounding tissue in a carefully regulated balance. Fluid leaves the capillaries to deliver nutrients to the tissue, and then is reabsorbed back into the capillaries and the lymphatic vessels to be returned to the central circulation. When this balance is disrupted, when more fluid is leaving the capillaries than is being reabsorbed and returned, fluid accumulates in the tissue spaces. This accumulated fluid is edema. The regulation of this fluid exchange depends on two competing forces: hydrostatic pressure, which is the physical pressure of the blood pushing fluid out through the capillary walls, and oncotic pressure, which is the pulling force created by proteins, primarily albumin, dissolved in the blood. These proteins attract water by osmosis, pulling fluid back into the capillaries from the surrounding tissue. When oncotic pressure is sufficient relative to hydrostatic pressure, the balance is maintained and fluid does not accumulate. When hydrostatic pressure is elevated, as in heart failure or venous insufficiency where blood is not returning efficiently from the legs to the heart, or when oncotic pressure is reduced, as in protein deficiency or liver disease where albumin production is impaired, the balance shifts and edema develops. Understanding these two forces immediately explains why sitting or standing for extended periods tends to worsen lower leg swelling. Gravity increases the hydrostatic pressure in the veins and capillaries of the legs when a person is upright for long periods, pushing more fluid into the tissue than the return mechanisms can efficiently remove. This is also why lower leg swelling typically improves overnight, when you are lying flat, because the hydrostatic pressure advantage of gravity is removed, and the lymphatic and venous return mechanisms can work more efficiently against a level pressure gradient. Now let me explain the primary nutritional deficiency that contributes to edema in a clinically significant way, because this is the central subject of this video, and I want to give you a thorough and accurate picture of the evidence. Vitamin B1, known as thiamine, plays a role in cardiovascular function that is less widely understood than its role in energy metabolism and neurological function. Thiamine is essential for the normal function of the heart muscle and for the maintenance of normal vascular tone, the degree of tension in the walls of blood vessels that determines their diameter and their resistance to blood flow. In thiamine deficiency, a condition called beriberi in its severe form and subclinical thiamine deficiency in its milder presentations, the cardiovascular effects include a form of heart disease characterized by high cardiac output, meaning the heart pumps more blood per minute than normal because the peripheral blood vessels are dilated and resistance is low, and fluid retention, specifically peripheral edema in the legs and ankles, that can be dramatic and that responds to thiamine supplementation. The cardiovascular form of thiamine deficiency-related edema, called wet beriberi historically, was a recognized and common clinical presentation in populations with inadequate thiamine intake before the widespread fortification of refined grains with B vitamins in the mid-20th century. It is less common in developed countries today, but it is not absent, and subclinical thiamine inadequacy, meaning intake below optimal levels without the full clinical presentation of beriberi, is more prevalent than most people realize, particularly in specific populations. The populations at highest risk for thiamine insufficiency include people who consume a diet high in refined carbohydrates and processed foods with limited whole grain, legume, and animal protein intake. People who consume alcohol regularly, because alcohol impairs thiamine absorption, increases thiamine excretion, and depletes thiamine stores. People taking diuretic medications long-term, because diuretics increase the urinary excretion of water-soluble vitamins including thiamine. People with diabetes, because thiamine transport into cells is impaired in the diabetic metabolic environment, and because high blood glucose increases thiamine excretion. People over 65, because absorption of many micronutrients declines with age, and dietary diversity often decreases as well. And people who have had bariatric surgery, or who have any condition affecting nutrient absorption in the small intestine. If you fall into one or more of these categories, and you have lower leg swelling that has been evaluated and does not have an identified structural cause, thiamine inadequacy is a clinically reasonable consideration. The evidence for thiamine's role in edema comes from multiple directions. Clinical case reports of patients with unexplained edema that resolved with thiamine supplementation. Population studies showing associations between low thiamine status and cardiovascular abnormalities. And mechanistic research showing that thiamine is required for the function of enzymes involved in energy metabolism in the heart muscle and in the maintenance of vascular endothelial function, the normal behavior of the cells lining blood vessel walls that regulate fluid permeability. The dietary sources of thiamine include whole grains, particularly the bran and germ portions that are removed in the refining of white flour and white rice. Legumes including lentils, black beans, and peas. Pork and other meats, sunflower seeds and flax seeds. Nutritional yeast and dairy products in smaller amounts. The recommended dietary allowance for thiamine in adults is 1.1 milligrams per day for women and 1.2 milligrams per day for men, which is achievable through diet alone with adequate intake of these foods. Supplemental thiamine for someone who is not severely deficient is typically taken in doses ranging from 50 to 100 milligrams per day, well above the RDA, but within the range considered safe, as thiamine is a water-soluble vitamin, and excess is excreted rather than accumulated to toxic levels. Now I want to discuss the other nutritional factors that contribute to lower leg swelling, because thiamine is not the only relevant nutrient, and a complete picture is more useful than a single answer. Magnesium deficiency contributes to edema through its role in regulating the movement of sodium and potassium across cell membranes. Sodium retention is one of the primary drivers of fluid retention throughout the body, and magnesium is required for the normal function of the sodium-potassium ATPase pump, the membrane protein that actively moves sodium out of cells and potassium into cells against their concentration gradients. When magnesium is insufficient, this pump function is impaired. Sodium tends to accumulate in cells and in the interstitial fluid surrounding them, and the osmotic effect of that sodium accumulation draws water into the tissue. Magnesium deficiency is extremely common in the modern diet, with estimates suggesting that a significant majority of adults in the United States consume less than the recommended daily amount. Dietary sources include dark leafy greens, nuts, particularly almonds and cashews, seeds, legumes, whole grains, and dark chocolate. Supplemental magnesium glycinate or magnesium malate are forms with good bioavailability and minimal gastrointestinal side effects at typical supplemental doses of 200 to 400 milligrams per day. Potassium insufficiency contributes to fluid retention through a related mechanism. Potassium is the primary intracellular cation, meaning the positively charged ion found predominantly inside cells, and it works in opposition to sodium, which is primarily extracellular. The ratio of potassium to sodium intake is a significant determinant of fluid balance, blood pressure, and edema tendency. The modern Western diet provides far more sodium than potassium, which is the reverse of the ratio found in whole plant foods that constituted the majority of the human diet for most of evolutionary history. Increasing potassium intake through dietary sources, primarily vegetables and fruits, legumes, and whole grains, supports the fluid balance that reduces edema tendency. Potassium supplementation above the amounts available in food requires caution and medical guidance, particularly for people with kidney disease or people taking certain blood pressure medications, because excess potassium can cause dangerous cardiac arrhythmias in vulnerable individuals. Dietary potassium from food is generally safe for people without kidney disease or relevant medication interactions. Vitamin C deficiency contributes to edema through its role in collagen synthesis. Collagen is the structural protein that forms the framework of blood vessel walls and capillary walls. When vitamin C is inadequate, collagen synthesis is impaired, and the structural integrity of capillary walls is reduced, making them more permeable and more prone to allowing excess fluid to leak into the surrounding tissue. Mild vitamin C insufficiency, below the level of full clinical scurvy but still below optimal, is more common than generally recognized, particularly in smokers, in people under chronic stress, and in people with diets low in fresh fruits and vegetables. Vitamin C from dietary sources, primarily citrus fruits, kiwi, strawberries, bell peppers, broccoli, and other fresh produce, supports capillary integrity and fluid balance in a way that contributes to edema management. Now let me address the lifestyle factors that work alongside nutritional interventions, because nutrition alone addresses only part of the picture. Physical movement is the single most effective immediate intervention for lower leg edema from the common benign causes. The calf muscles, when contracting during walking, serve as an active pump for the venous blood in the lower legs, squeezing the veins and propelling blood upward against gravity toward the heart. This mechanism is called the skeletal muscle pump or the calf muscle pump, and it is essential for adequate venous return from the lower extremities. Prolonged sitting or standing without movement allows venous blood to pool in the lower leg veins under the influence of gravity, increasing the hydrostatic pressure that drives fluid into the tissue. Regular walking breaks, ankle circles and calf raises performed while seated or standing, and any form of calf-engaging movement interrupts this pooling and activates the venous return mechanism. Even 5 minutes of walking or lower leg movement every hour during a prolonged sitting period significantly reduces the end-of-day edema that many people experience. Compression garments, specifically graduated compression stockings, provide external mechanical support to the veins of the lower legs, counteracting the hydrostatic pressure that drives fluid out of the capillaries. The compression is graded, meaning it is highest at the ankle and decreases as it moves up the leg, which is specifically designed to encourage venous blood flow upward rather than allowing it to pool. Compression stockings are one of the most evidence-supported non-pharmacological interventions for lower leg edema from venous insufficiency and from prolonged sitting and standing. They range from over-the-counter support stockings at 15 to 30 millimeters mercury of compression for general use, to prescription-grade stockings at 30 to 40 millimeters mercury or higher for clinical venous insufficiency. For most people with mild to moderate positional edema, over-the-counter compression stockings in the 15 to 25 millimeters mercury range provide meaningful benefit. Elevation of the legs above heart level for 30 to 60 minutes per day, ideally in the afternoon or evening, when edema is typically at its worst, allows gravity to assist venous and lymphatic return from the lower legs. Lying flat with the legs propped on 2 or 3 pillows, so that the feet are higher than the hips, is sufficient. This simple positional intervention, done consistently, reduces the end-of-day fluid accumulation that most people with positional edema experience. Sodium reduction is relevant when dietary sodium intake is high, because sodium is the primary determinant of extracellular fluid volume in the body. The kidneys regulate sodium excretion and therefore fluid volume, and a diet chronically high in sodium causes the kidneys to retain more water to maintain the appropriate sodium concentration, which increases overall fluid volume and contributes to the pressure that drives edema. Reducing sodium intake below 2,300 milligrams per day, the current recommended upper limit, and ideally toward 1,500 milligrams per day for people with significant edema, reduces this fluid retention contribution. The primary sources of dietary sodium are not the salt shaker, but processed and packaged foods, restaurant food, cured meats, canned soups and vegetables, and condiments, which together account for the majority of sodium intake in most adults. Hydration, paradoxically, supports edema reduction rather than worsening it. The instinct when experiencing fluid retention is often to drink less water, but inadequate hydration causes the kidneys to conserve water more aggressively, worsening fluid retention. Adequate hydration, indicated by pale yellow urine throughout the day, supports normal kidney function and normal fluid regulation. Let me now address some of the herbs and natural compounds that have evidence supporting their use for edema management, because this is an area where some useful options exist alongside significant misinformation. Horse chestnut seed extract contains a compound called eskin that has documented effects on capillary permeability and venous tone. Multiple clinical trials have found that horse chestnut seed extract standardized to eskin reduces lower leg edema in people with chronic venous insufficiency, with effect sizes comparable in some studies to compression stockings. It is taken orally at a dose typically providing 50 milligrams of eskin twice daily. It should not be used during pregnancy and should not be used with anticoagulant medications without medical supervision, as it has mild blood-thinning properties. Butcher's broom, an extract from the plant Ruscus aculeatus, has been used in European herbal medicine for venous insufficiency and lower leg edema, and has some clinical trial support for modest effectiveness in reducing edema in people with chronic venous insufficiency. It appears to work by increasing venous tone, reducing the tendency of veins to dilate and pool blood. Dandelion leaf, available as a tea or a dried herb, is a natural diuretic that increases urine output and can temporarily reduce edema by increasing fluid excretion. Unlike pharmaceutical diuretics, dandelion leaf replaces some of the potassium lost through increased urine output, because dandelion is naturally high in potassium, which is a meaningful practical advantage. It is not appropriate as a treatment for edema from serious causes, but is a reasonable supportive measure for mild positional edema. I want to close with the red flags again, because I said them at the beginning, and I want to repeat them at the end, because their importance warrants repetition. Sudden swelling in one leg, swelling with redness and warmth in one leg, swelling with shortness of breath or chest pain, swelling with decreased urine output or foamy urine, and swelling in the context of known heart disease or kidney disease, all warrant medical evaluation before any home intervention is begun. These are not situations where a nutritional approach is the appropriate first response. For the person with gradually developing bilateral lower leg swelling that is worse at the end of the day, that improves with elevation overnight, that is associated with prolonged sitting or standing, and that has been evaluated and does not have an identified serious underlying cause, the combination of thiamine adequacy, magnesium and potassium sufficiency through diet, adequate vitamin C, sodium reduction, regular movement breaks, leg elevation, and graduated compression stockings constitutes a comprehensive, evidence-informed approach to managing the most common benign form of peripheral edema. Tell me in the comments how long you have been dealing with lower leg swelling, whether it is worse at a particular time of day, and whether you have had it evaluated medically. I read every comment and I answer as many as I can, because the specific pattern of the swelling is informative and helps me give more targeted information in the replies. Next time I am going to cover the relationship between blood sugar regulation and fluid retention, specifically the mechanism by which insulin resistance contributes to sodium retention and edema, and the dietary interventions that address this specific pathway. I will see you then.